Welcome, everyone. Thank you for joining our webinar today with Elizabeth Tobin-Tyler and Joel Teitelbaum, authors of The Essentials of Health Justice, which was just published this past April. Professors Tobin-Tyler and Teitelbaum will be talking to us today about the different angles on the structure and social barriers to health. My name is Suzanne Walker, and I'm the Senior Marketing Manager for Public Health and Health Administration here at Jones & Bartlett Learning. For those who are not familiar with Jones & Bartlett Learning, we are a provider of instructional assessment and learning performance resources for the secondary, post-secondary, and professional markets, specializing in areas of health and safety. Before we get started, I'd like to review a few housekeeping notes. The formal part of this presentation is roughly 40 to 45 minutes. Since we have quite a few people registered for today's webinar, we've muted all your lines. Therefore, we won't be taking questions during the presentation, but rather encourage you to type your questions in the question box located in the panel on the right side of your screen. At the end of the presentation, the authors will answer those questions. Additionally, we will be recording today's webinar. After the webinar has ended, you'll get a link emailed to you so that you can listen to the webinar at any time that's convenient for you. Now let's move on to the presentation. It is my pleasure to introduce you to our two presenters today, Elizabeth Tobin-Tyler and Joel Teitelbaum. Elizabeth Tobin-Tyler is an assistant professor of family medicine and medical science at the Warren Alpert Medical School at Brown University. She teaches, writes, and consults on the areas of health policy, health equity, and public health law and ethics. Her research focuses on the role of law and policy in the social determinants of health, community-based and health system interventions that address health disparities and interprofessional medical legal education. Joel Teitelbaum is an associate professor and director of the Hirsh Health Law and Policy Program and co-director of the National Center for Medical Legal Partnership at the George Washington University Milken Institute School of Public Health. He also carries a faculty appointment with the GW Law School, and for 11 years, he has served as vice chair for the academic affairs in the Department of Health and Policy Management. Professor Teitelbaum has taught graduate courses on healthcare law, healthcare, civil rights, public health law, minority health policy, and long-term care law and policy, and an undergraduate survey course on health law. He was the first member of the School of Public Health faculty to receive the university-wide Bender Teaching Award, and he has received the School's Excellent in Teaching Award, and he is a member of the GW Academy of Distinguished Teachers. And now I'd like to turn things over to Joel. Joel?
Thank you, Suzanne, for that overly long introduction, but we appreciate it. And thank you to all of you who have joined the webinar today. It is really a wonderfully diverse group of courses and interests that you all represent. We were able to see, of course, the list of people who had signed up, and it really is an incredibly diverse and rich group of you and a really interesting set of courses and interests that you all have. So we're glad to see that this topic is crossing lots of different boundaries and disciplines. So a quick roadmap for today, 3 parts basically. I'm going to start by talking about the role of discrimination and bias in health and healthcare. After that, I'm going to talk just very briefly, really as an introductory matter, about civil legal aid as a social determinant of health. There's just going to be one slide on this and a few points that I'll make in order to better set up Liz's presentation. She's then going to talk more broadly about law as a structural determinant of health. And this tracks more or less how we have structured our recent book, which is called Essentials of Health Justice, which is that we pulled out discriminant bias separately and early in the book, given its historical and enduring effect on people of color and other minority populations. And then we cover the myriad ways in which law, structural barriers, and health are interconnected. So we're basically doing something like that here today. So we're going to begin part 1, the role of discrimination and implicit bias in healthcare. I've got a couple of framing quotes here. They're here just to stick in the back of your mind. I have a whole list of quotes that I keep on hand, and I pull different ones out for different presentations depending on the topics. These really just sort of set the frame for something that we might be talking about today. So the quote from Dr. Martin Luther King, which you've probably all seen or heard before, which every condition exists simply because someone profits by its existence, certainly relevant during today's discussion. And then the second one by William Osler, who a very famous Canadian physician and one of the founding professors of Johns Hopkins Hospital. He said, ask not what disease the person has, but rather what person the disease has. And when you're talking about things like structural and social determinants of health, it is quite relevant. So the place to start is with a few terms. I think it's important both to use these terms when you're talking about things like structural determinants of health and discrimination and implicit bias, when you are teaching, when you're meeting with students, when you're doing your other kinds of work. And it's important not just to use the terms, but also to use them correctly. So I've got 4 up here. The first one is prejudice, which is a preconceived bias not based on someone's experience. Discrimination is when a person's prejudice is used in action. So in other words, the unjust treatment of different categories of people. Racism is a specific type of prejudice in which a member of one race believes that his or her race has qualities that render it superior to other races. And then implicit bias, which we'll come to in a little bit, which is bias in judgment and or behavior that results from subtle cognitive processes that often operate at a level below conscious awareness and without intentional control. Now, discrimination and racism are often used interchangeably because of their similarities. And while it's true that they fall under the broad umbrella of prejudice, the ideas have very significant differences. Discrimination is a much broader term. It can be used to describe the unjust actions of minority groups in general, rather than being specific to race. So, for example, a person can obviously discriminate against people in the LGBTQ community without being racist towards them. So again, important to use the terms and talk openly about these terms, and then also to use them correctly. Focusing in on discrimination, discrimination can be expressed on 3 different levels. The first one is interpersonal, where the unfair treatment of a person or a group of individuals occurs. For example, if someone is denied a job or an apartment rental based on that individual's race. Internalized discrimination occurs when the victims of discrimination internalize the prejudicial attitudes towards themselves and or quote unquote their group, which can result in, among many other things, stress and a loss of self-esteem, both of which are health harming. And then finally, there's structural/institutional discrimination, and these are prejudices that are built into policies, laws, and societal practices. Structural discrimination can be particularly wicked. It can be rooted, for example, in very overt racism from decades or even centuries ago, but can result even today in unintentional discrimination as policies and practices are passed on through the generations, and you'll hear more about this during Liz's presentation. Let's talk specifically about race-based health disparities. So needless to say, all racial and ethnic minorities, the impoverished, religious minorities, people with disabilities, women, and others have all been excluded from the healthful benefits associated with full participation in society. But for purposes of today's presentation, for purposes of time, we're going to single out race discrimination and African Americans specifically. There are many reasons for racial health disparities. I am sure that most of you out there on the webinar are well aware of this and the many causes of racial disparities. For example, I've got a few up here: the historical disinvestment in social services, which disproportionately affects people of color, neighborhood safety, environmental hazards, and many, many more. But the literature suggests that one central cause is played by the chronic financial hardship caused by centuries of exploitation and segregation, as well as the direct toxic effects of discrimination on both mental and physical health. So here are just a few examples from what I'm sure, again, most of you know to be a very large and ever expanding body of literature. So for example, we know that Blacks have elevated death rates, not just morbidity, but mortality rates when compared to white counterparts for things like cancer, stroke, diabetes, kidney disease, maternal health, and many, many other conditions. The research also shows that daily experiences of African Americans create physiological responses that actually lead to premature aging. In other words, these folks are biologically older than their chronological age. In fact, every 7 minutes, a Black person dies prematurely. That is more than 200 Black people each day who would not die if the health of Blacks and whites were equal. Some other statistics, this is in the third bullet on this slide. This is taken from a recent study that was conducted by the Robert Wood Johnson Foundation, the Harvard School of Public Health, and NPR. African Americans were asked about their own personal, direct, specific experiences. 32% reported that they have experienced race discrimination when going to a doctor or to a health clinic. 22% avoided seeking medical care out of concern about discrimination. 31% avoided calling the police when in need to avoid potential discrimination. 45% have been discriminated against when trying to rent or buy a home, and 27% avoided day-to-day tasks as simple as using a car or participating in social events. So the point of some of those latter statistics is that it's not just avoiding a doctor that can lead to poor health. Not calling the police in the event of an emergency can risk safety and protection. Safe and stable housing is, we know, one of the most foundational needs for good health, and avoiding interaction with others can result in social isolation, which itself is also linked to poor health. For a very concrete example, I would encourage you to read the Michigan Civil Rights Commission's report on the 2017 Flint water crisis. In this report, the commission focused on three major issues. One, the structures, institutions, and systems that created Flint itself, the place, including the history of segregated housing and education in that geographic area. Two, environmental justice. And three, the role of implicit bias. The commission concluded that a complex mix of historical, structural, and systemic racism combined with implicit bias led to decisions, actions, and consequences in Flint that would not have been allowed to happen in primarily white communities such as Birmingham, Ann Arbor, or East Grand Rapids. So it does make for a very interesting and bracing read. So I mentioned implicit bias. That was part of the Michigan Civil Rights Commission report. So it's a good segue into talking briefly about implicit bias as a correlate of health and well-being. So what makes implicit biases so enduring is that, generally speaking, individuals consciously hold non-prejudiced beliefs and do not realize that they are being motivated by implicit biases. Yet research shows that these quote-unquote automatic beliefs, which all of us have, are deeply held and can guide behaviors in ways that contribute to persistent inequality. Just last year, a federal court was very blunt in its assessment that implicit bias is, quote, no less corrosive of the achievement of equality, unquote, than explicit and overt discrimination. So I have a few examples here that are specific to health in this first bullet. These are three separate studies. The first, the majority of physicians agreed that their own implicit race bias may affect their treatment decisions. A second study found that pediatricians' biases lead them to prescribe less pain medication to African American children than for white children. And in the third study, physicians said that they are less inclined to recommend blood clot surgery for Black patients based on the quote-unquote perception that they are not as cooperative about treatment recommendations as are white patients. So the possibilities that would connect implicit biases to health and well-being are in some ways endless. I've just given you two examples in this second bullet here. It's food for thought, but again, there are many, many others, and we talk about others in the book. For example, if everyone has these implicit biases, isn't it possible that officials who are charged with administering health programs could make policy decisions that are based on these unconscious views? And isn't it in fact likely that instructors and mentors in the health professions can pass along their biases to the next generation of care providers, thereby perpetuating unequal treatment? So obviously, oftentimes when you're talking about implicit biases, the conversation turns to what do we do about them? How do we respond to them? How do we counteract them? So rather than pretend that implicit biases don't exist, Experts in the field of implicit bias in psychology and neuroscience encourage people to equate an implicit bias with a bad habit, which means that you've got to acknowledge that you have the habit, you have to analyze the habit, and then you have to overcome it by a non-prejudiced response. Some of the methods that have been used to try and combat implicit biases include consciously replacing stereotypes with counterexamples in your own life, using role-playing games in which individuals imagine themselves in the position of the victim of bias, something called individuation, which is in which medical students are taught to prioritize a patient's individual characteristics rather than their membership in a particular group. And then innovation such as implicit bias rounds, where healthcare providers consider how implicit bias may have detrimentally affected their past care of their patient population. So let me switch gears now. I'm looking at the time, and I want to kick this over to Liz in just a few minutes. Let's talk a little bit about civil legal aid to help set up Liz's presentation. Civil legal aid is a determinant of health. So the U.S. is one of the only countries in the world that completely separates access to criminal and civil legal services. So in a nutshell, what that means is that most of you are probably very familiar with the concept that people who are charged with a crime have a right to access counsel. That's enough to say for our purposes. There is no such right when it comes to what we call civil law, which is non-criminal law. So all the other events that might lead someone to want to file a lawsuit or believe that they have been harmed in some way or discriminated against in some way, there is no right to legal counsel in all of those cases. And I'll come back to that in just a second. You can see from that second bullet that we here in the U.S. rank 94th out of 113 countries in the accessibility and affordability of civil justice. And there are 65 million people who last year qualified for federally funded legal aid. This federally funded legal aid comes in the form of what's called LSC funding, or Legal Services Corporation funding. LSC is a congressionally chartered independent organization. Congress controls its purse strings. Congress decides how much money it gets every year, and then the Legal Services Corporation fans that money out across the country to over 100 legal aid organizations in various communities in all of the states as a way to try and provide some legal aid for individuals who are too poor to be able to purchase legal services themselves. Now, that sounds like it's a great thing that there's a federally funded organization that provides legal aid and that there are 65 million people who qualify. The big problem is that it is only funded, LSC is only funded to the tune of about 2 million people. So the vast majority of low-income individuals who would qualify for federally funded legal aid are not able to get it, period. Now, the reason that is so important is that if you think about all the different kinds of civil legal needs that people might have, this could relate to their housing, to their insurance status, to their immigration status, to their insurance status, to education needs, disability, a whole range of things. Those are things that we now identify as social determinants of health. So what we used to sometimes think about as simply a housing problem, we now recognize it to be a health-harming housing problem that might have a remedy in civil law. So if all of those people with all of those needs don't have access because there's no right and there aren't enough resources, then that means all of those social determinants of health that are affecting their health in negative and corrosive ways are not being met by the civil legal aid community. So a few closing thoughts, and then I'll kick it over to Liz. The first thing is that discrimination and bias against people based on an immutable trait or membership in a particular group are two of the more unsavory social determinants of health to talk about, but we singled them out, again, both in the book and in this presentation, to call them out for what they are, an enduring component of our society and our health system that relegate far too many people to the fringes of well-being. We would ask all the same of all of you in your discussions and in your teaching and in your writing, and that is to confront our nation's past openly and to admit the existence in all of us of our own implicit biases. My second bullet here, my second closing thought, is that we must promote law as the main tool by which we have historically attacked civil rights abuses, inequity, and social pathologies, and Liz will pick up on this thread. And then finally, we should promote emotional and cognitive empathy, neither of which are solely hereditary. It's not as if someone is either born with the empathy gene or they're not. There is some scientific evidence that people are more genetically empathetic than others, but empathy can be taught and it can be learned, and it is something that we probably need to do more of in this country. Now, I am going to take a moment to change the presentation over to Liz. If you'll give me a second. And I think we've done so successfully. So Liz, take it away.
Okay, thank you, Joel. And thank you, Suzanne and Jones Bartlett Learning for giving us this opportunity today. So I'm going to pick up where Joel left off. Joel has really focused on the ways in which particularly discrimination and bias influence health and well-being and really drive health inequities. And he's begun to touch on sort of the role of law in perpetuating those inequities. So I'm going to kind of turn to that discussion of role as a structural, what we call a structural determinant of health, and try to give some examples of the ways in which social inequality in the US has a downstream effect on the health of vulnerable populations. So I wanted to start, and again, Joel has sort of alluded to some of the distinct characteristics, I think, of the US in terms of structural inequality. This is from a book from Wilkinson and Pickett, The Spirit Level, which basically tries to quantify the way in which specifically, in this case, income inequality drives social problems in different countries. And you'll note that the US is far on the right top corner there in terms of having high income inequality, which is along the bottom of the chart, and having a greater index of health and social problems. And those are sort of listed out on the left, including things like life expectancy, learning and literacy, but many of the things that in public health we track: infant mortality, homicides, teenage births, obesity, mental illness. And so when we think about the role of inequality in our society, and its role in social problems and public health problems, it's pretty clear to see. The other thing that's fairly uniquely American is that we medicalize social needs. So this may be a chart that many of you have seen. It's been talked about quite a bit in the literature in the last couple of years. But in terms of our spending in the United States, you can see that we spend substantially more on medical care than we do on social care. So we spend upwards of 16 to 17% of our GDP on healthcare, while about 9% goes to social care. And that's quite different if you look at other comparable countries in the way that we invest in social needs. And we know that we have far worse health outcomes, as I've just described earlier, that really clearly seem to be driven by social inequality. So what is the role of law in as a determinant of health? So there are kind of 5 different ways that you can think about this and the way that law plays a role at multiple levels as a social determinant of health. First of all, law can be used to design and perpetuate social conditions that can have a terrible physical, mental, and social, emotional effects. So if you think about what Joel has just been talking about, particularly with historic discrimination in this country, laws that created and continue to perpetuate things like racial segregation clearly lead to poor access to healthcare, to education, to resources and communities that continue to have a significant effect on vulnerable populations, particularly populations of color. A second way to think about this is that law can be a mechanism through which prejudices are transformed into distributions of relative well-being among populations. So again, Joel alluded to this, but the underinvestment, as I've just described, in adequate social supports for vulnerable populations, including an inadequate safety net for things like healthcare, food access, and housing. All of these things create a differential between access to resources for different populations and has a significant impact on people's health. A third way to think about this is that law can drive health disparities through selective enforcement. So this can work in a couple of different ways. One is that laws that are intended to protect health and safety are very frequently not equitably enforced. So I'll talk about this in a little more detail in a minute, but things like housing code laws that are intended to protect health and safety very often go unenforced or underenforced in particularly in low-income communities. But there are also laws that may be selectively over-enforced in particular communities. So, for example, criminal drug laws are often enforced in low-income neighborhoods, whereas they might not be in higher-income neighborhoods. And this obviously has an impact on the population there and the population's health. A fourth way is that laws can be interpreted in ways that can actually help or hinder health. So if you think about court interpretations of laws, they frequently have an enormous effect on health. So, for example, the Supreme Court's decision a number of years ago after the passage of the Affordable Care Act that Medicaid expansion should be an option for states as opposed to required for states. We know from research studying this that has had an enormous disparate effect on both access to health care, depending on which state you live in, but also health outcomes in states that did not expand Medicaid. And then finally, a fifth way is that laws can actually structure direct responses to health harming social needs that result from things like indigence, illness, and market failure. So on the flip side, laws can be directly targeted to improve health and actually try to address inequality. So if you think about a whole range of different laws that may have to do with things like neighborhood redevelopment that are actually intended to improve the conditions in which people live, then that that is another way that law can be an important social determinant of health. So I sort of just mentioned a number of these, but if we kind of think about the spectrum of people's basic needs and what it takes for people to be and stay healthy, this can encompass a whole range of issues like income and insurance, and the way that we structure our safety net programs or other types of entitlements are critically important to whether or not people have access to their basic needs. They have basic income, so that may encompass things like insurance. It may encompass things like food stamps, disability benefits, Social Security benefits, or protecting people from debt in cases of debt. Another one, and I'll emphasize this more in a few minutes, is around housing and energy. So people having actual access to housing, the conditions of their homes, and access to utilities is critical. In the vein of education and employment, there are a number of laws that protect people based on their status. So that may have to do with things like compliance with the Americans with Disabilities Act, protecting people in the workplace from discrimination or in education, protections for children with disabilities, and other kinds of employment protections that may affect particularly low income and low status workers more directly. We also consider things like legal status, and certainly all of the issues that we're dealing with now around immigration status have an enormous effect on people's health. There was actually a study that came out just a couple of days ago from the Harvard School of Public Health that was monitoring preterm births for Latina immigrant women, and it found that preterm births have actually gone up among Latina immigrant women with many of the changes in immigration policy in the last couple of years. So, how laws are structured are critically important, and the way that those laws are interpreted and understood by the public are important to people's health as well. And then things like criminal record issues, which can create enormous barriers for people. So I'm going to just take a couple of minutes to kind of try to spell out in a little bit more detail what we've been talking about with regard to how we see these different issues play out as structural determinants of health. So I mentioned an inadequate safety net. This is really driven by, I think, the particular way that we view poverty in the United States as an individual responsibility, and really creating an attitude about the safety net that it is problematic to expand a safety net because it means that that people are taking advantage of government benefits when they shouldn't be, as opposed to looking at a safety net as basic to people's health and basic to public health. So things like SNAP, housing subsidies, and support for early childhood development have all been shown to benefit public health when people actually receive those kinds of benefits. But in fact, because of a whole range of bureaucratic issues and eligibility issues and just lack of funding, many people are not actually able to access those kinds of things. And then this really, we know quite clearly from the research that poverty in and of itself is closely correlated to long-term poor health outcomes. But we can see how this manifests in different ways in terms of the relationship between poverty and things like adverse childhood experiences. Much of the literature on that suggests that there are pretty significant consequential poor health outcomes for children that have experienced a number of adverse childhood experiences, including things like poverty. In people having to make decisions about how they take care of themselves and their families through making choices about whether they heat their home or they have enough food on the table, and those kinds of decisions at the ground level are driven by a lack of adequate safety net and income. But it also means that many people suffer from health consequences of, for example, not having heat in the winter or having food insecurity. And then the sort of cycle of eviction and transience and homelessness are clearly associated with poor health outcomes. So I mentioned earlier that under-enforcement of particular laws has a significant impact on health. This includes existing legal protections that are actually intended to protect people, like the housing code protections for low-income tenants, or legal protections for victims of domestic violence. But as Joel noted, one of the critical things to think about with under-enforcement is that this lack of adequate access to legal assistance, essentially renders many people with rights that they have little opportunity to actually exercise and enforce those rights. So if you think about this from the perspective of health justice, access to justice or access to legal assistance may be critical in keeping somebody in a safe and stable home, which we know is closely linked with poor health outcomes. Another way to think about this is that we criminalize social deficiencies. So, if you look at the populations of people that end up in our prisons, many of them have mental illness, disability, are very often come from impoverished neighborhoods. This issue of selective enforcement of criminal drug laws obviously plays a role in who ends up in prison and the significant racial disparity that comes along with that. But this also plays out in terms of collateral consequences of having a criminal record. So when people come out of prison, very often African-American men who make up a larger segment of the prison population are then barred by their criminal record from accessing housing, accessing employment, and very often accessing things like SNAP benefits. So the idea of a second chance is often really not the way that we think about these issues in our culture. And this has significant impact not only on the health of the person coming out of prison, but the impact of entire neighborhoods that are affected by people that have gone to prison and have come back from prison and who have families that live in those neighborhoods. So it has a larger collateral consequence, not just for the individual, but also for the family and the community. And then I just wanted to come back briefly to the issue of housing, because I think this demonstrates sort of the cycle and the interrelationship among the different laws and policies that play out in terms of structural inequality. So we have no particular entitlement to housing in this country. We have a safety net that is severely inadequate in terms of providing low-income people with access to housing. This leads to a crisis of eviction because many people cannot afford the homes that they attempt to rent in the private market, which also leads to homelessness. So affordability clearly plays a role in people's access to just basic housing. But what this also can do is it forces many people to live in inadequate housing that is unsafe and that creates significant health threats. So we know rates of lead poisoning, including in places like Flint, Michigan, but also all around the country based on the kind of housing conditions that people live in. There's a much higher rate among communities of color and low-income children. This is also true for things like asthma that are exacerbated or sometimes caused by significant housing hazards that people live with. And then the third piece of it, as I mentioned earlier, is energy access. So, tens of thousands of people every year have their energy sources cut off for non-payment because they're not able to afford those energy sources. And, that can lead to all kinds of significant health problems for both vulnerable, ill, elderly people as well as children. And so there's a whole range of different issues when it comes to housing that impact public health. So we try in the book to lay all of these issues out and to try to help students and faculty think about the best ways to talk about these issues, but we also want to provide some ways for people to think about how do we strive for health justice and what are some of the ways that we're trying to do that now, what are some of the ways that those that are concerned with these issues can move forward. One is to continue to advocate for investments in a safety net and for recognizing that the safety net plays a key role in public health. Another is that we stress the importance of equitable enforcement of civil legal rights. So as we've both talked about, even if we have good laws on the books, often those laws are not adequately enforced, and people, particularly vulnerable and low-income people, do not have access to legal assistance to actually exercise their rights. So access to justice is critically important. It's a severely underfunded, as Joel mentioned, resource for people to be able to exercise their rights. So advocating for better access to justice is critical. And then there's a whole range of healthcare delivery system reforms that are really focused on trying to address the social determinants of health. So advocacy within the healthcare system that recognizes not just that people need referrals to social services, but also that there needs to be efforts to really look at what the structural barriers are to those services, and for the healthcare system and healthcare providers to be engaged in that kind of advocacy in their own communities to recognize where they can advocate for better supports for people in their community. We ask students in the book to really think about different levels of policy advocacy. Very frequently, we focus on federal policy, but in fact, there are many state and local laws and policies, as we've talked about briefly here, that have an enormous impact on people's health. So being clear about what in our own communities, what types of laws and policies create barriers for people, or what are some of the health promoting laws that we can promote in our own communities. And then finally, educating the next generation across disciplines. So it's very, as Joel said, very heartening to see the different types of people that are on the webinar today, and from very many different disciplines and perspectives, and trying to think about how to encourage students across disciplines to struggle with these issues, and then to really think about ways that they can get involved and be active in trying to create legal and policy changes that are going to benefit vulnerable populations is critical. So I will stop there and see if we have questions.
Okay, this is Suzanne. Most of the questions center around the availability of the slides and a recording. We will have a recording which will be sent out in a link to you probably tomorrow or the next day, within the next 24 to 48 hours. So that will have the complete slide deck as well as the audio, the presentation today. So that will be available probably shortly. Another question here is, will teaching resources be available for the textbook? And which kind of teaching resources? Joel or Liz, do you want to talk a little bit about the teaching resources that are available to accompany the book?
Sure. This is Joel, and unfortunately, Suzanne's referring to the lack thereof. So, when this textbook was proposed, and as it was written, it is meant to be supplemental, probably, to another book that someone might be using in a course. And so, because of its length and because of its topic area, we were looking to fill a need and fill a market in this very specific area that we assumed would be taught as part of a larger course where there would be a primary textbook. Now, it is certainly possible that faculty are out there using the book or perhaps creating courses that might be, say, 1 credit in length, where they would just be using this as the sole textbook. We thought that would probably be the very rare instance. So for the time being, we have not thought about doing much in the way of additional resources because we assumed this was going to be used as an additional resource. So we're happy to think about perhaps slide decks for individual chapters, perhaps some discussion questions, that sort of thing that we do for other Jones and Bartlett Learning longer full-length textbooks. But again, this book is pretty new to the market, and so we haven't had a lot of feedback yet. If it's something that you all on the call are interested in, we'd probably welcome, and I'll kick it back to Suzanne for this, we'd probably welcome to get that kind of feedback. I don't know what the appropriate forum is, but Suzanne, if I've said anything that doesn't sound correct, please fix that for me.
No, that sounds perfectly reasonable. You can either get in touch with me and I can forward those on to Liz and Joel. So if you have suggestions on the types of materials that would be most useful to you, by all means, contact me. It's swalker@jblearning.com. And I know some of you have reached out to me through the webinar. We have a number of other questions here that are a little more substantive, and so I'd like to get to some of those because there's some really good issues here. Progressive tax policy would promote our ability to address the social determinants of health. We seem to be moving in the opposite direction. What do you suggest?
Well, I think certainly we would agree with that. And I think, again, it comes down to people raising their voices and advocacy around helping our policymakers to understand the implications of our current tax policy and what that is likely to do for public health and for health justice. And I wish I could give a silver bullet about how to get our policymakers to think differently about tax policy. But I think it suggests that we all need to get engaged in that type of advocacy.
And I would just throw in that I would have to agree with the person who asked the question. The Tax Cuts and Jobs Act of 2017 is probably going to be one of the more destructive laws that we've seen in the modern era in terms of both income and economic inequality, and also probably down the line population health, although it's going to take some time for the research to bear that out. But the questioner is absolutely right that we're moving in the wrong direction if that law is any indication.
Okay. I have another question here. What are your thoughts on how to more widely roll out advocacy systems like medical legal partnerships to address the injustice discussed?
I can start, Joel, and then I'm happy for you to jump in. We both do a lot of work around medical legal partnership. And I would say one of the encouraging developments is that increasingly health systems are recognizing medical legal partnership as an important part of holistic care for patients, and to some degree are beginning to finance medical legal partnerships as part of team-based care. A lot of that is coming through a recognition of trying to shift from fee-for-service payment for healthcare to value-based payment, and a recognition that in order to reduce healthcare costs overall and improve access to care and quality of care, that, including things like medical legal partnerships that, address legal issues as part of healthcare is critical. Maybe I should just say, since I'm assuming people know what medical legal partnerships are, but I don't want to make that assumption. So a medical legal partnership is essentially embedding lawyers or legal experts into healthcare teams that serve vulnerable populations in order to address some of the social and structural determinants of health that we've been talking about today. So they really work, hand in hand in collaboration with healthcare providers, social workers, community health workers, and others to identify when patients and patient populations are experiencing legal barriers or other types of structural barriers to health, and try to problem solve around those as a team.
And I'll just add one thing to that, and it's certainly related, and that is, I think one of the best things that we have going for us is coalition building. So much in the same way that the purpose of a specific medical legal partnership is to combine forces on the ground, I think if we're going to really be able to push some innovative strategies and interventions that can make some differences upstream as opposed to sort of being back-end fixes in moments of crises or ill health or discrimination or what have you. I think we've got to start looking across disciplines and working in an interdisciplinary fashion, and that means in large part for the folks that are coming out of their undergraduate and graduate training in the future is that they have to learn in an interdisciplinary fashion. They have to understand the language of one another's work. So whether you're talking about medical care and public health and social work and law and public policy students, somehow training together or learning together, I think that's pretty critical so that when they come out of their own studies, they're comfortable with the concept. It's something that they want to do. It's something they see value in. But I don't think we're going to get too far down the path of these kinds of innovative solutions. And I say that as the co-director of the National Center for Medical Legal Partnership, unless we get better about ingraining in current students and in our own work the idea of coalition building and working together with different fields and different disciplines. I think that's probably where our strength lies.
Okay, great. I have another question here. What kind of rights do citizens have when the community they live in is imposing health risks like pollution in the case of Salt Lake City? Specifically, the industry has not been regulated enough and there isn't enough public transportation to combat commuting. This is on top of the normal weather pattern of inversion every winter. The rates of asthma and other respiratory illnesses have skyrocketed. And that's the end of that comment. Any suggestions on the rights that citizens have when they're in a polluted environment like that? That's not being regulated?
Liz, do you want to go first or second on that one?
Well, you can go first. I'm happy to jump in after.
Yeah. So the answer is it depends, because obviously state and local laws are going to differ across the country. So you may find some remedy in a local ordinance. You may find a remedy in a state law that may not exist in a different state. At the federal level, the answer is almost nil if you're thinking about an individual's ability to enforce some sort of civil rights or environmental law in a particular instance, having to do much with the way that the federal courts, including the Supreme Court, over the past 30 or so years has started to interpret what it means to have a private right of action to enforce some of these civil rights and environmental laws as individuals, but instead we're expected that the enforcement agency of the federal government, so for example, I think in the questioner's case, you'd be talking about perhaps the Environmental Protection Agency, the expectation would be that that federal agency that has enforcement responsibilities in that particular field would be doing the enforcement on behalf of individuals who file claims. So the answer is there's sometimes there are remedies to be found in state and local laws. Infrequently, there are remedies, less and less frequently, there are remedies to be found in federal law.
Okay, great. And a couple comments on your book and also some resources. Looking forward to this book as it's so very much needed. Not sure if I missed it. Can you tell us more about the book name availability, which is Essentials of Health Justice? They also want to know the suggested level of student to use the book with, undergraduate. And I think Liz and and Joel have all kind of mentioned it, but just to put it formally out there, it's called Essentials of Health Justice, a primer, and it's available on our website at go.jblearning.com/Tyler. Joel or Liz, do you want to talk about the level that it's written at?
Yeah, I can take that one, Joel. So we really tried to write the book intentionally for multiple audiences, including undergraduate level and graduate level students. So although we talk a fair amount, as we have in this webinar, about law, both of us, I think, do interdisciplinary teaching and are very cognizant of how best to convey issues around law to students in public health and nursing and medicine. I teach medical students here at Brown. So it's really intended for multiple audiences to help them understand from their own perspective or vantage point or training how to think about issues around social determinants of health from a justice perspective. There's a lot of curriculum now, I think, in public health and medicine and social work and a lot of different, in nursing, a lot of different fields focused on the social determinants of health. So it was really our goal to help students kind of think beyond the description of something as a social determinant of health to understand how it implicates law and policy, and how to think about underlying structural issues that might need to be addressed to improve health.
Okay, great. Another person commented here, I was thrilled when health justice came out and wanted to learn how to teach the textbook. I'd like to develop an assignment that gets my students working on advocacy. Any ideas for topics or ways to get that going?
So I spend a fair amount of time teaching advocacy to medical students. So obviously it partly depends on the discipline that you're teaching. I often do case-based studies initially with students to help them think about how they might put into action an advocacy plan around a particular issue. So I've done one on asthma and housing and the housing code, and trying to help them think about where they might advocate for changes around what's considered a housing code violation and better enforcement of the housing code on behalf of low-income tenants. So that's an example of sort of thinking about advocacy at that level. I also have students select a bill that's pending at the state level here in Rhode Island that somehow implicates health, and ask them to study the issue and the bill, and then to write testimony and to try their best to actually give that testimony at the State House on their bill. So I think, trying to engage students in not only thinking about how to advocate on a particular issue, but looking for opportunities for them to actually do that. I realize I'm in Rhode Island where the State House is very close by, so not everyone can do that. But there's certainly other administrative law opportunities to speak at state agencies or to promote a particular issue with community organizations that are working on those issues, joining so as Joel mentioned, sort of coalition building advocacy efforts as well. I don't know, Joel, if you have other thoughts.
No, I do much the same. I mean, there's so many perhaps dismal or unfortunate examples right now from which to choose that are real world, that are happening right now, in terms of picking topics around which you can build avenues of advocacy. And so, like Liz was saying, I mean, what I also do is either I pick a topic myself, or depending on the size of the class, I let students pick topics, and then using different sources, other writings, other chapters, other textbooks. I have them learn how to write a policy analysis, and then using that particular topic, draft a policy analysis, and then we work through the various iterations. And so in that way, they're learning both content and substance, but they're also learning a skill, one particular skill of policy advocacy, which is how do you write, a very short 2-page policy memo that someone will actually read, because obviously there are few people who are in policy making positions right now that want to sit down and read 30 or 40-page briefings about each individual topic. So learning to write a policy analysis is a skill in and of itself. And so in that way, you can combine both the skill and the content.
And I would just add that I think a very good example of sort of a policy issue that's significantly important right now, that also can help students understand the importance of providing their voice in the administrative context, is the public charge rule that has just been released by the Trump administration, that would change the way that immigrants would be considered a public charge. I don't want to go into too much detail, but many of you have probably read about this, that it would significantly impact a lot of immigrants, including immigrants that are living legally in the country, if they're determined to be a public charge based on the types of safety net programs that they're taking advantage of. And because it's a administrative rule that's been released, there's an opportunity for public comment on that. And that's an excellent opportunity for students to link the potential health consequences of a particular a rule coming from the executive branch, and how to think about public comment and how to frame a public comment. So that's just an example of an exercise that has, real-time impact right now.
Those are great options. I did have a person here who offered a number of other resources which might be valuable to the group as far as supplementary materials. This person offers one possible resource is NACCHO, NACCHO, Roots of Health Inequity course. And that's at http://www.rootsofhealthinequity.org. And another possible resource is Social Determinants of Health Case Studies. And that URL too is https://www.teachpopulationhealth.org/SDOH cases HTML.html. So I will provide those in follow-up email as well. And there's one final question here, which is probably to you or Joel. Can we get an internet address of a successful medical/legal partnership?
It's unclear. I don't know what is necessarily meant by a successful medical legal partnership. If you are looking for medical legal partnerships that have been, say, around for a fair amount of time, and therefore have been able to create sustainability, create continuity, create real integration across partners, and create a space for themselves in the community. A few stand out, and I don't mean to single anyone out at the expense of any other medical legal partnership. There are about 330 of these in the country right now, and so it's not as though I can list them all. But the original one in Boston which is MBLP, Medical Legal Partnership of Boston, does some really interesting and wonderful work around workforce capacity, legal health in New York City, pairs with Health and Hospitals of New York, which is the largest public hospital system in the country, across 11 different hospital sites to do some really fascinating and innovative work around everything from immigration to veterans. Cincinnati Children's Medical Legal Partnership and Seattle Children's Hospital Medical Legal Partnership are doing some really innovative and forward-thinking work. And then there's several others, some of which I would just point out are highlighted in a recent series that we've been promoting on the National Center for Medical Legal Partnership website. It's a Patients to Policy series, and there's 5 of them up right now, each one highlighting the specific policy work of an individual MLP. And those are very current and I don't think involve any of the 3 I just mentioned. So that would give you 5 additional examples. So you can get, excuse me, you can get lots of information on our resources page at the National Center's website.
Great. Some other people are offering some additional suggestions. Somebody mentions legal health in New York City as another resource. I'll put all these links in the follow-up email. Another example that I've experienced with is the Neighborhood Legal Service Partnership with the AYA Cancer Program at the USC Keck School of Medicine alongside the Norris Comprehensive Cancer Center and CHLA. So, and AYA means adolescent and youth adults. Thank you, Kathy. So all of these links will be sent along shortly. And I believe that covers all our questions today. I want to thank everybody for attending the webinar today. And we will, the recording will be made available along with links that we talked about today in a follow-up email tomorrow. So once again, thank you, Liz and Joel, for your time and very thoughtful presentation. And thanks everyone for attending today. This ends the webinar. Thank you.